My name is Moby Parsons, and I am a shoulder arthroplasty surgeon practicing in Portsmouth, New Hampshire at the Knee, Hip, and Shoulder Center. I'm one of the design surgeons for the Exactech GPS, or Guided Personalized Surgery Navigation System. This talk will review the background and rationale for this technology and will hopefully convince you that we as surgeons should be leveraging technology to ensure that we do the best job possible to position shoulder implants in a manner that maximizes fixation, restores anatomy, and provides durable implant longevity in treating degenerative conditions of the shoulder. My disclosure is that I serve as a consultant for Exactech related to the design of this technology. We know from prior studies that anatomic reconstruction of the shoulder correlates with better functional results. And I think this is particularly true on the glenoid side, which is considered the weak link in shoulder arthroplasty. We are now seeing some pretty dismal midterm results of anatomic total shoulders, particularly in cases with more severe glenoid wear. We're all familiar with the bulge classification system, and recently there has been recognition of a higher glenoid failure rate in cases of the B2 and B3 glenoid felt to be partly due to subluxation of the humeral head. We also know from our own preoperative planning research that glenoid deformity is prevalent, and it's not always well recognized because it is difficult to see the Z-axis, and therefore advanced imaging is critical. The deformity may also affect the shape and depth of the glenoid vault, which is where implant fixation is achieved. We are also learning more about the limits of version correction through corrective reaming and the potential negative impact of subchondral bone violation to long-term glenoid implant stability. And with all these factors in mind, the more information that we have to accurately balance version correction, implant fixation, and bone preservation, the better we will be able to neutralize the pathologic forces that lead to both pathologic wear in the native glenoid as well as potential glenoid implant failure after shoulder arthroplasty. Biomechanical studies have shown us that glenohumeral translations increase with increasing humeral retroversion. These translations result in eccentric loading of the glenoid implant in shoulder arthroplasty and the so-called rocking horse effect that can lead to implant loosening. We also know from finite element studies that placing the glenoid implant in progressive degrees of retroversion increases the forces in the cement fixation, which can lead to progressive micromotion and loosening. The problem is that we are not very good at accurately correcting glenoid version, particularly in cases of advanced wear. Dr. Iannotti has shown that freehand pin placement based on preoperative planning may be off axis by as much as plus or minus 10 degrees in both version and inclination, even in very experienced hands. And this means that despite having an image in your mind of where the K-wire should go for optimal corrective reaming, even experienced surgeons can rarely reproduce this plan and can be off by as much as 30 degrees in the worst case scenarios. The use of patient-specific instrumentation can improve this accuracy, but the average error is still as much as plus or minus 7 degrees in version and inclination. If a patient's normal retroversion is 5 degrees, this could result in implant placement in a range anywhere from minus 12 to 2 degrees of anteversion. These errors translate into changes in the loading mechanics across the joint and again may increase shear forces that can ultimately lead to premature implant failure. A meta-analysis by Sadogi et al. Showed that the average error in glenoid retroversion was nearly plus or minus 11 degrees, and that this could be improved approximately 6 degrees with the use of navigation, and this was felt to be statistically significant. The implication from these studies is that in general, we are not very good at correcting glenoid version using conventional techniques. The other implication is that most of us do not realize how bad we actually are at this, as we have no way of quantifying our error at the time of surgery, nor knowing the final version of the implant at the conclusion of the case. Given the frequency of glenoid wear and the importance of correction and humeral recentering in the B2 and B3 glenoids, this is essentially unacceptable given today's technology. We have done our own studies to validate the accuracy of the navigation system. And when we look at our own data from 7 shoulder arthroplasty design surgeons using cadaveric specimens, we see that free-handing glenoid implantation relative to a set preoperative plan has a huge variability, as seen by the blue points on the scatter plot. And much of this data was collected in specimens without significant pathologic wear. This variability is likely magnified in complex cases. When these cases were navigated, the variability was markedly reduced, as shown by the tight cluster of red points. What this data suggests is that navigation is helpful for every single case, not just the ones we think are challenging due to wear and deformity. The conclusions from what we know to date are that even experienced shoulder arthroplasty experts do a poor job at positioning both primary and reverse implants. Secondly, malposition of the glenoid implant may have a direct effect on its durability. Eyeballing it in the OR is no longer good enough, and our clinical follow-up data is beginning to bear this out as patients put higher demands on prosthetic implants. With the technology available today, we need to do better, and there really are no excuses for implant malposition or outliers. The central problem is that visualization at the time of surgery is limited to the glenoid face, and this, along with the vault behind it, can be significantly altered by arthritis in ways that are difficult to appreciate from just an en face view. We cannot see the Friedman axis, the posterior wall of the glenoid vault, the base of the supraspinatus fossa, the scapular spine, the spinoglenoid notch, and the medial trigonum. And thus, we cannot fully appreciate the shape and orientation of the glenoid face and vault relative to the scapular axis with any degree of accuracy without the help from technology. The goal of GPS is to greatly increase the accuracy of glenoid correction relative to a patient-specific preoperative plan. If the red data points are what we can achieve with patient-specific instrumentation, we aim to improve upon this while simultaneously allowing intraoperative real-time visualization of the glenoid preparation in 3 dimensions. The workflow for this starts with a CT scan protocol that captures 1 millimeter cuts through the glenoid. This is then put through a segmentation process that allows accurate rendering of the scapula and alignment of the axial, sagittal, and coronal planes relative to the scapular axis. The Friedman axis is also determined at this point, and the plan is then uploaded into a preoperative planning platform, which allows selection of the appropriate implant and customized placement to achieve the desired correction. This plan is then transferred to a computer in the operating room with a tracking system that allows navigation of the surgery by registration of the scapula with the CT scan and the use of intelligent instruments that allow execution of the plan with a high degree of accuracy. This shows a close-up of the planning software, which allows adjustment of the implant depth, rotation, superior, inferior, and anterior, posterior position, along with version and inclination. Images can be viewed in either 2 dimensions or 3 dimensions to determine the optimal position of the central cage or peg in the glenoid vault and any potential peg perforation. We can also quantify the degree of corrective reaming needed to achieve the desired version and inclination, as well as proper seating of the implant on the prepared glenoid face. The image on the right shows the intraoperative view for drilling the central cage hole, and this can also be viewed in 2 and 3 dimensions to ensure accurate reconstruction and preparation. The goals of preoperative planning start with understanding the pathologic anatomy. The appropriate implant can then be selected for either primary or reverse total shoulder arthroplasty. This implant can then be positioned to achieve optimal fixation and correction of pathologic glenoid wear, and this can be reconciled with the goal of minimizing bone loss and avoiding potential peg perforation, scapular notching, or potential impingement. When we surveyed the design surgeons on the team about planning priorities, 7 out of 8 surgeons ranked minimizing bone loss as the most important, followed by preventing peripheral peg perforation, and finally achieving a fixed degree of version correction. Interestingly, 1 surgeon did rank achieving a fixed degree of version correction as the top priority. What we are trying to avoid are complications that are the direct result of improper implant placement, including malposition, scapular notching, and improper screw placement, or even screws that are fully outside the bone. Fortunately, our system provides many different options for dealing with different patterns of glenoid bone loss, both in primary and reverse shoulders. For the reverse system, this includes a standard base plate, an 8-degree posterior augment, 10-degree superior augment, and combined posterior superior augments, as well as a standard implant with an extra long cage. For the primary shoulder, there are pegged and keeled implants, as well as a hybrid cage implant. The cage implant comes in a standard and 8-degree posterior augment, and there is also a 16-degree posterior augment for an all polyethylene pegged implant. We looked at augment usage among our design team for a series of 44 cases derived from our planning database. And these were real navigation cases with real pathology. The average retroversion in this series was 14 degrees, but ranged from 4 degrees of anaversion to 26 degrees of retroversion. And this table highlights the utility of augmented glenoids, demonstrating that they were used in 64% of anatomic cases and 76% of reverse cases. What this indicates is that when you can more accurately quantify glenoid wear and plan a specific degree of correction that optimizes loading mechanics, implant fixation, and bone preservation, augments are used more than half the time. Without planning and navigation, our historical records showed that we used them in only 15 to 20% of non-navigated cases, which means that these cases were likely either left in residual retroversion or required greater subchondral bone removal during corrective reaming. This graph shows the frequency of anatomic glenoid implant types according to retroversion angle. It demonstrates that standard implants were never used when retroversion was greater than 12 degrees and rarely used when it was greater than 9 degrees. 8-degree augments were used across the spectrum, but most commonly when retroversion was more than 8 degrees. The 16-degree augment showed increased usage with more severe retroversion. And if you're wondering why the 8-degree augment would be used in cases with less than 8 degrees of retroversion, it is again a matter of balancing optimal loading mechanics, fixation of the implant within the glenoid vault, minimizing peg perforation, and minimizing bone loss. When you balance these factors, particularly in cases where the vault may be narrow from central wear, there are times when an augmented glenoid satisfies these goals better than a standard one, and this would not be anticipated without the aid of planning and navigation. The more cases you plan and the more you see the variability in vault morphology, the more convincing it becomes that this technology is necessary in all cases, even those that seem straightforward at first glance. We have done validation studies on cadavers and determined that the GPS navigation is accurate to within 1.6 degrees of version and 1 degree of inclination, and roughly 1 millimeter of anterior, posterior, and superior inferior placement. This depiction shows the comparative accuracy of different techniques, demonstrating that the combination of planning with navigation greatly improves a surgeon's ability to place the glenoid implant over preoperative planning alone without navigation. This point is worth emphasizing that planning by itself is helpful, but not enough to provide the kind of precision that we should be achieving in every single case. Again, this scatter plot demonstrates that we cannot reproduce our plan without some type of navigation, no matter how good we think we are. In challenging cases with substantial glenoid erosion and bone loss, precise placement is essential to ensure solid and durable implant fixation. I would argue that while experience and skill can certainly play a role in these cases, there is no substitute for the added information that live navigation can provide, and understanding where the remaining bone is and where the implant should go. Revision cases can also be done using metal suppression techniques and careful image segmentation. This case shows the use of a combined augment to convert this failed total shoulder to a reverse. You can see the severe cavitary and segmental bone loss. The surgeon has chosen to implant the base plate at 0 degrees of retroversion. This would be extremely difficult to achieve with a freehand technique. Our data proves that without planning in combination with navigation, even the skilled shoulder surgeon does a poor job with glenoid implant placement. We also do a poor job of actually knowing the final position of our implant with this technology, which makes it very difficult to reconcile clinical performance with loading conditions we have created at the time of reconstruction. In truth, without GPS, you really don't know what you're missing, and there is no reason not to use this in every single case.